Hello, my name is Parita Patel, and I'm from University of Chicago. Dr. Dalal and I have co-authored an article titled Hepatic Manifestations of Inflammatory Bowel Disease. The manifestations of inflammatory bowel disease extend greatly beyond the GI tract and can have significant interplay with the hepatobiliary system. In fact, approximately 5% of patients with IBD will develop chronic hepatobiliary disease, while abnormal liver tests can be seen in up to 30% of patients with IBD. We will first discuss the associations of Primarysclerosing cholangitis, or PSC, and IBD. PSC can be progressive, and continued destruction of the bile ducts can lead to portal hypertension and potentially liver failure. A high clinical suspicion for PSC is needed in patients with IBD and abnormal liver tests, particularly in those with an elevated alkaline phosphatase. The diagnosis is made by demonstration of multifocal stricturing and dilation of intra or extrahepatic bile ducts on cholangiography. While a liver biopsy is not needed, it may provide diagnostic information, particularly in patients with small duct PSC or in patients with an overlap syndrome. Concomitant IBD and PSC significantly increases the risk of colon cancer, particularly in patients with ulcerative colitis. Patients with ulcerative colitis and PSC are almost 5 times more likely to develop colon cancer and dysplasia compared to patients with ulcerative colitis alone. As a result, guidelines recommend annual colonoscopy screening from the time of diagnosis of PSC. There is also a higher risk of peristomal varices in patients with an ileostomy after a proctocolectomy, and in those who develop portal hypertension from progressive PSC. Bleeding can be treated with a liver transplant or a transjugular portosystemic shunt, or TIPS. Patients with ulcerative colitis who undergo an ileoanal pouch anastomosis are more likely to develop pouchitis compared to patients with IBD alone. Treatment of patients with IBD and PSC is similar to those with IBD alone and should focus on treatment of complications and alleviation of symptoms. Possible medical treatment options include ursodeoxycholic acid and immunosuppressive agents, such as azathioprine, infliximab, and cyclosporin, but none have been shown to improve the course of the disease. Endoscopic therapy for dominant strictures may also improve symptoms. Liver transplant remains the only established option for PSC, with a 5-year survival rate of 80 to 90% and a 20% rate of relapse. Moving on to non-alcoholic fatty liver disease, or NAFLD, and IBD. NAFLD is a clinical pathologic syndrome with a wide histologic spectrum ranging from steatosis to non-alcoholic steatohepatitis, in which inflammation and apoptosis can lead to devastating fibrosis and cirrhosis. The pathogenesis of NAFLD in patients with IBD is not yet clearly elucidated, but may involve dysbiosis of the gut microbiome, long-term use of medications such as steroids, and duration of IBD. Treatment options for any patient with NAFLD include weight loss with lifestyle modification, decreasing risk factors for cardiovascular disease, and even bariatric surgery in select patients. Lastly, many drugs used for the treatment of IBD can cause hepatotoxicity. In this review, we discuss several drugs, including sulfasalazine, azathioprine, and methotrexate. We review the type of liver injury that can be seen with these medications and the proposed mechanisms of action of liver injury. In conclusion, abnormal liver enzymes are frequently encountered in patients with IBD, and a thorough evaluation is required to correctly identify the etiology. Early diagnosis can lead to earlier treatment and potentially an improved prognosis. Thank you very much for your time.